afternoon, everyone. First, I would like to welcome everyone, all the attendees, and also Dr. Ali Mogdad to our second seminar of the QBRI webinar series. My name is Judy de Kock, and I'm a scientist at the Cancer Research Center at Qatar Biomedical Research Institute. Today, it is my pleasure to introduce you to Dr. Ali Mogdad. He is professor at the Institute for Health Metrics and Evaluation and Chief Strategy Officer for Population Health at the University of Washington. Prior to his position at the Institute for Health Metrics and Evaluation, Dr. Ali Mogdad also worked at the CDC Center, and he has done some groundbreaking work on different local level disease trends and leading risk factors for poor health. His work on obesity, for example, is among the most highly cited in the field. The Institute for Health Metrics and Evaluation provides projections for different countries to guide their responses to pandemics such as COVID-19 pandemic we are experiencing today. The projections that they provide give also estimates of the resources that would be needed, such as hospital beds, ventilators, and so on, as well as scenarios for strategies that could be used by policymakers. In this webinar, Dr. Ali Mogdad will briefly highlight the model that they are using at the Institute, as well as his projections for Qatar, and discuss the strategies to reduce the spread of COVID-19 in Qatar. So with this, first of all, I would like to also highlight some housekeeping rules. The first one is that all the microphones of attendees are muted, but we would like to encourage you to submit questions in the Q&A tab, not the chat tab, and to address it to all the panelists. So this way we can be sure that we capture all the questions. And then at the end of Dr. Ali Mogdad's lecture, we will have the Q&A session. So without any further ado, I would like to give the floor to Ali Mogdad at the moment. Thank you so much.
All right, good morning, everybody. So I'm gonna talk about our IHME projections for Qatar and what are the strategies to reduce the spread of COVID-19 in Qatar. So we are a large team working on the projections here at IHME, led by our director, Christopher Murray, of course. We have 9 faculty working on this, but about 96%. The model that I'm presenting started by hospitals here, part of the University of Washington Medical Center, asking us to prepare for the surge, how many beds they would need, how many ventilators, and how many ICU beds they need. So we started running these models for our own university here, for our own hospitals. And of course, other hospitals asked us to do the same. And now we're running it for every country in the world, of course. But originally it started at the request of our hospitals here to be better prepared for COVID-19. And what our model is looking at is how many deaths are likely to occur between now and we have a 4 months time period. Now we go until November 1st. We have internal data that goes all the way to January 1st. And what are the daily deaths expected and when it is supposed to peak. So that's originally our model was to chase when it will peak and what will happen after the peak. And then during that phase, we wanted to know at that peak, when is the peak for ICU needs? So we know what shortages will hospitals have, how many ventilators are needed, how many infections are happening on a daily basis, and how many total infections. And we wanted to provide scenarios of what will happen if people wear a mask, for example, or if nothing is being done in a country or a place, what will happen here. So the IHME model follows daily deaths. So we look at the percent change in death rate from one day to a day. So that's what we're looking at. We're also looking at total deaths, of course, which is cumulative deaths. And then in that model, we use mobility, which is a indicator that we have data on from several sources, Facebook, Google, SafeGraph, and Descartes Lab, where we know from surveys, people telling us how much they wear a mask and people telling us from their app when they move from one place to another, we know how much mobility that is in each location. And we also take into account testing, how many tests are happening, because early on we knew that testing would mean finding cases early, isolating them, through tracing, and that way you will reduce the rate of infection. And of course, confirm what countries are reporting in terms of infection, and then we provide estimated infection. So if a country is reporting every day, say 100 cases, there are more cases in the population that haven't been tested, and we provide that estimate as well. So briefly, how the model has changed. We have three models, three versions of the model right now. We're in the third version of the model. The first model was a curve fit. Basically, we looked at deaths at that time because we didn't have infection and we didn't know how many people are infected due to lack of testing early on in the pandemic. And that model, which is a curve fit, did extremely very well by predicting when the peak will happen and the shape of the curve as it goes up. However, that curve fit model assumed it's a bell-shaped curve. So it goes up, it comes down the same way. And we know that's not the reality in many countries for COVID-19. We've seen this happen in China early on. That's why we use that model. We've seen it happen in Italy, went up and it came down. We've seen it in many places in Spain and Madrid. It goes up and it came down so fast. But that wasn't the case here in the United States. So the model did very well predicting the peak, but it wasn't a symmetric decline. And we had to switch to another hybrid model where we use susceptible, exposed, infected, and recover. And that model took the 8 days in the past and found a relationship between our covariate, deaths, and infection and projected it to the next 8 days. And basically, we take all these covariate and we project them to the future, and then we take all the estimates from past 8 days. All the data is telling us what's happening, what's the relationship between these covariate, and it's projected to the future. And it takes into account a lot of covariate early on. We looked at mobility testing, and we had temperature early on and population density. But once we moved a little bit until June, when we were through the pandemic here in the United States, we realized that even that model is not doing very well. The SEIR is very good, but the curve fit is no more relevant because of many states and many countries reached a peak and were coming down. So we moved to a random knot, and I'll talk a little bit more about it, random knot methodology, and added it to the SEIR model. And in that model, we use different covariates. By having more data, it allows us to look at more things, and it allows us to go into random knots. We didn't have the capacity to do so before. And the random knots model, and I'll explain a little bit more, uses mask from the surveys in Google and Facebook, takes into mobility, Google and Facebook premise here in the United States, pneumonia seasonality, and I'll show you why pneumonia seasonality is there. Testing per capita, population density, a variable particulate matter 2.5 as a measure of pollution, smoking, altitude, and pneumonia death rate, of course. So let me briefly show you what we mean by this random knot combination. So if you look at the top here, top one, this is cumulative deaths by time, and this is state of Alabama, just to give you an idea. I'll show you the same for Qatar later on. But because Alabama has hospitalization, and I want to tell you how hospitalization data, once we have it, and we don't have it for every place, how it helps us in our model. So the top left one, cumulative deaths, shows you by time how cumulative deaths is changing. And the reason we wanted to look at cumulative deaths, not a daily confirmed daily death, because daily deaths, if you look at the one below it, it goes up and down. So one day, and we have noticed in many places, in many states, in many countries, some states here don't report deaths on Saturday and Sunday, and they were reported on Monday, or sometimes they report the deaths on Monday, but Tuesday they report the week. And we see that patterns in every country in the world. Again, no criticism, but countries are doing a lot of work. So sometimes over the weekend, getting the data, compiling it, and releasing it. So the daily death goes up and down. So we use cumulative deaths. The second one, if you look at cumulative case rate and cumulative death rate, so number of deaths and cases and deaths, and we're modeling that. We're seeing the relationship between cumulative cases and cumulative deaths. And we feel deaths in many places and many countries is a very good measure because people reported it certain extent, I'll talk more about it, corrected. So we can find this relationship between cases on a daily basis and cumulative death rate, and we can find how cumulative death rate changes over time, which we are trying to predict the increase from daily to day. In the middle one, you see daily confirmed cases, and this is in Alabama. It goes up and down, of course, a function of testing, a function of reporting. Now in the US and in many countries, because of so many tests are being done, sometimes there is a delay in reporting. So the case arrives as Tuesday, but the test has happened on Friday or Thursday in certain places. In the US right now, there is in places that are delayed 3 to 5 days to get the results, which makes tracing and isolation irrelevant because everybody doesn't know we have a case or not. But the daily confirmed cases, as you can see towards the end here in Alabama, it goes up and it's coming down. And it goes up and down. And then the last one, the bottom one on the right side is hospitalization. Alabama, we have hospitalization on a daily basis. So you could see how many people were admitted for COVID-19 in hospitals in Alabama. That's a very good indicator because you know hospitalization, you know how many have been admitted, how many cases have been reported, so you know cases who have been tested, how many showed up to a medical care, how many are still in the community and haven't showed up at the medical care. From those who were admitted, you know how many have died. From those who have died in total, you know how many have been admitted. From those who are admitted, you know how long they stayed at the hospital. Did they need an ICU? Did they need a ventilator? And you could do this calculation. So the bottom left here is the daily death is smoothed right now. The red line is following the death rate, taking into account admissions, cases, and then infections that are reported. And you see that messy, it's doing that. The red line is doing the smoothing and predicting the daily deaths. And we're doing this for the past. We can validate that into right now. So we can take 6 weeks ago and validate what happened 2 weeks ago because we have the data. And what I want to draw your attention here at the one is this big confidence interval because it's a messy data. You could see it. It's following the peak of during the peak, sometimes around May, towards the first couple of weeks of May, you see the peak in daily deaths in Alabama. You could see a wide confidence interval when we were doing our prediction because there is a lot of variation here between cases, but it's coming down. And right now, because of the rate of the case and daily confirmed cases, the decline is not as high as we've seen before. So our model is saying in Alabama, it's going to go up a little bit right now because we see these trends from the data that's available. Briefly, the susceptible, exposed, infected, and infectious, we believe there is an I1 and I2. I1 is somebody who gets infected, may not become infectious immediately. We know right now that some asymptomatic cases are they're spreading the virus, and we know sometimes that even before the symptoms shows that some people are being infectious and they're spreading the virus. So we have this 2I, infected and infectious, in order to a mean for us to adjust for those as we have more data coming to us eventually from antibodies or from PCR tests when people are catching up with the number of tests. Recovered could be somebody who went through the disease but got is cured and recovered. Unfortunately, sometimes could mean death here. And we have in our model that I'm not showing here a mean to bring people back into the susceptible pool. And this is at the request of many countries. They wanted us to tell them what happens if they open the airport, if there are people who are infectious that come in and be added to the population. We're trying here to model what we call beta, which is this function that's changing over time. And from beta, we can tell what is the effective R and what's the infection rate. And the formulas that I'm putting here, this is the only slide that have formula. Our math department, we have two faculty in the math department who work with us at HME as well, figured out a way to make it simple for us. And all of these, we do it by draws. So basically, we take a 1,000 draw, assuming that when you become infected, it takes 2 days for you to become infectious. And then we run 1,000 more. we change the parameters. Then we say, now what happens if we become infectious in one day, we run another 1,000 row and so on. Then we fit that model and see how does it fit the real data that we have. And we validate that model. So we're doing ensemble model, and it tells us the data driving what models we need to use and what variables we need to choose. In and all of this, and once you have the random knot, it feeds into SEIR, and then that's how we run. So we do the random knots first, we feed it to SEIR, and we have two models running on separately. That's why it's called a hybrid model. In our models, we have several variables. Some are very important and they remain in our model. And our modeling technique is slightly different. We don't decide what variable is a good predictor. We do it the reverse way. We say what variable, if we don't have in our model, will make our model go crazy. So one of the most important variable we have is pneumonia seasonality. That COVID-19 is following pneumonia seasonality. The second one is mobility. And mobility has changed from our second model to our third model. And the reason is the following. Early on, mobility before the mandates in Qatar was totally different, for example, than mobility after the mandates, because now people are very careful when they go out. So mobility is now totally different than before. People are wearing masks, trying to stay away from each other. There are measures in place to limit infection, whereas in the past, these didn't exist. Mask using and testing per capita are very important. Again, testing per capita is a significant variable, but in some of our states, for example, right now in Florida, where on Sunday, they had 15,000 reported cases. Before it was 10,000 and 9,000. So when you reach a point where you have in a state like Florida, about 10,000 cases a day, the capacity to do tracing and isolation becomes very limited because you don't have the manpower to do it. So testing will become less relevant as we had it before when there were few cases and you're able to catch them and move them. The other variables that are kind of constant, we can change, are four to change with time because we have data on mobility and mask use and testing from every country. With pneumonia seasonality, we have deaths on a weekly basis from pneumonia, so we can adjust for that. Population density, particulate matter, smoking prevalence, altitude, and others. These are variables that we have from our GVD. There's some change with particulate matter throughout time, but they're constant in a way, and we add them to our model. Lots of data sources that we have. We get data from ministries directly through collaborations because of our global burden of disease and our collaborators. And then, of course, we use the COVID tracking project. We get all the data that Johns Hopkins had, all what's be reported by WHO, of course, because we have an MOU with WHO. Facebook Data for Good, which are the surveys that talked about. And of course, as I mentioned, the Descartes Lab, Cytograph, and Google. And in the US, it's premise data that we use. We have 5 different scenarios that we present in our projections. Let me talk about the second one here. The second one is business as usual. So we keep opening the business and we're not imposing any mandate. So, and we know that no country will allow this to happen if the rates increase so high. Then the first one that we provide and we give a number for is current projections, where the mandate will be reimposed for 6 weeks whenever mortality reach 8 per million. And we looked at that. This is a 95th percentile of when other countries imposed the mandates in the past. So we took it as, we didn't take the high, we didn't take the low, we took the 95%. The third scenario is, what if everybody wears 95% of the population wear a mask? And again, we have a reimposing of the mandates for 6 weeks when the 8 million is reached, 8 deaths per day per million. 95% of the mask was chosen because we have seen it happens in Singapore, for example, and in Hong Kong, where mask use is around 95%. So we felt if a country can do it, other countries can put such a mandate in place and people will adhere to it, knowing that it will save lives and will save the economy because it will delay another mandate and closure of business. And we have 2 other scenarios. What if when you reach a 5 per million, you shut down for 2 weeks and open for 2 weeks? And what if you shut down for 2 weeks and open for 6 weeks when you reach 5 per million deaths per day? Let me show you how some of these variables and how they are in our region. Percent of people who say they always wear a mask, you could see a huge variation. Qatar is doing a great job. The Gulf in general is doing a great job. Saudi, Qatar, and United Arab Emirates more than Oman and Kuwait. But you look at Yemen, for example, Sudan, Tunisia, Iraq is not as much, even in Palestine, not as much. Globally, you can see a huge variation in mask wearing, and the one that I want to draw your attention is if you look at parts of Brazil, Argentina, Chile, South Africa, where you see a large percentage of people wearing masks because now they're through the winter, fall and winter, and mortality from pneumonia is going up, so COVID-19 is going up, and that's why they have a high rate of mask wearing. And you could see it in Asia, Japan, and Korea. Traditionally, after SARS 1, people in Asia learned a lesson, and basically they are very good about wearing masks and keeping a safe distance. This is testing per 100,000 in population. Again, Qatar is doing extremely very well. The Gulf countries in general are reporting higher rate of testing compared to other countries, Jordan, Lebanon, or Palestine, or Egypt. Of course, no testing is going on in Yemen and in Sudan and in Somalia. This is testing throughout the world. Even in the United States, you could see a huge variation in testing, and you could see in the Northeast where the pandemics had the highest burden, New York, you see a high rate of testing. Not so much in Africa, as you can tell here. And that's average mobility in our region. The decline in mobility, Kuwait here is one who has the highest reduction. Again, remember, these are surveys from Facebook and Google. So these are people who have a smartphone. So they will tell you what's happening among the rich and affluent population, doesn't tell you what's happening among the guest workers in these countries, in the Gulf countries, or poor people in Egypt, for example, poor people in Lebanon, are they wearing a mask or reducing their mobility? So has a limitation here. Not so for Qatar, but possibly for the population, the workers, foreign workers who are in. That's mobility all over the world, and you could see in many places in the United States that mobility hasn't gone down that much from baseline when we started monitoring COVID-19, whereas in places like Kuwait, it's still down, and places in India, it's still very much down. And again, Chile, Argentina, parts of Brazil, it's very down because of the seasonality of COVID-19. If you look at pneumonia mortality, this is for past 5 years, the last year on the right-hand side. This is in the United States. You could see it go up and comes down in the US, and in Qatar, it's coming down right now. So in a way, when COVID-19 hit us in the United States and in Qatar, it was at a time when the seasonality and the weather was working to our advantage. This will change come September in the United States, when pneumonia season will pick up, which comes around the same time as flu season. It will pick up. But COVID is following the pneumonia, not the flu season, because in the United States, come May, we don't see mortality from flu, but we still see reduced mortality from pneumonia. And COVID-19 is behaving similarly to what we see in pneumonia. And that's the strongest variable in our predictions. If you take that variable out, our model doesn't perform well at all. So COVID follows exactly the pneumonia. And why we believe it is true as well, because if you look what's happening right now in Chile and Argentina, strict lockdown, but the cases are going down. This is the probability of effective R being above 1, which means the infection rate will go up. You could see it, it's high in Iraq, Iran, Morocco, Libya, and Qatar is above 1, but the probability of it being above 1 is a little bit lower than the other countries, and I'll show you why. That's the mean effective R. People talk about R not at the beginning of the infection, but R is changing throughout the time. And you could see here that in Yemen, Iraq, and Saudi Arabia and Egypt, it's above 1, and we expect the cases to go up. That's the last data we have for affected. That's Qatar affected. Went down after the lockdown, went up sometimes, maybe around the holiday, the Eid. There is a Eid effect in most of the countries. Then it came down. And now the data is showing that with the easing of the restrictions and people are getting out and letting their guards down, it's slightly going up right now above 1. So something to keep in mind as we have this discussion. This is Qatar, the data that we have for Qatar. Same what I showed you for Alabama without the hospitalization. So we're looking at date and cumulative death rate, top left. Top right, we're looking at cumulative case rates by cumulative death rate in Qatar to find out that relationship. You could see it was going up, kind of exponentially, diagonal, and it's still going up towards the end even more. The cases in Qatar, reported cases, peaked up and coming down, but if you look towards the end, that decline has slowed down. It's not dropping down as fast, and in fact, couple of days before it went up, then it came down. So our model is kind of confused. What's happening here? Cases were coming down, but now they're slowing. Mortality was still picking some deaths here. So what's going on? And the model has a wide confidence interval. Basically, it's telling us it's, I think it's going up, but possibly with a wide confidence interval because of this huge zigzag that you see in cases and daily deaths in Qatar. The model is like saying, it could be either way, wide confidence interval, but best guess, knowing from other countries what's happening, when you start relaxing and everybody is susceptible for this virus and people start letting down their guard, you would see infection going up. We see it in every country in the world. So unfortunately, it's something to be careful and worried about. So Qatar, these are our projections for Qatar. We project by November 1st about 530 deaths in Qatar, about 391. That's like almost 140 deaths less if people wear a mask, the green one. If people wear masks, 95% of people wearing masks. So the numbers, 530 deaths is a lot for Qatar, but we need all of us to remember that this could change by wearing masks and changing our behavior, keeping a safe distance. The daily deaths, we expected a peak that happened in June. We've seen a peak that happened in June 8, it came down. Now we see it going slowly up. Again, the wearing mask mandate, if people wear masks, the green one, mortality will keep going down. We don't expect it to go up to the June 8 level, even by November 1st. So mask alone will reduce it and will keep it below a peak, what has Qatar seen before. If we don't wear masks and business goes up to usual and we don't pay attention and roll some of the mandates back, sometimes toward the end of September, it will go, the observed deaths, again, smooth here, we're talking 2.9 deaths, will go higher than what we have seen in June 8. So something to keep an eye. And here is the daily deaths. And you can see the zigzag in the reporter. That's why the model is so confused. So it goes up one day, it comes down. In June 19th, that was the highest reported of deaths, but sometimes there is 0. The next day it goes up, and then it comes down, goes up. So that has been a little bit of a challenge for us for many locations when the population is small and the deaths is very few of the deaths, what's happening there. Daily infections, we're expecting about, during your peak on May 22nd, we expected about 1,700 infections in Qatar. If mask wearing is not implemented, we expect by November 1st about 5,000 infections will be, so that's scary in a way and calls for precautions and being very careful. We don't expect in Qatar there'll be a shortage of beds. Qatar has a very good medical system. You could see the top is how many beds are available, even in the worst case scenario by November 1st, when it comes to admission. Qatar will not have a shortage of beds. But if no masks and if the mandates keep rolling out, Qatar may have a challenge with ICU beds come November 1st if the cases increase as we are expecting. So it's something to keep an eye on and be careful with. We talk about social distancing. When the mandates came in, if you look at March, mobility went down, by about 45%. Sometimes in the first week of April, it reached about minus 50%. And it went up, and after the peak, it went up. I guess this is an impact of Ramadan, the holidays, and it came down. And then now with easing the mandate, it's going up rapidly. So right now we are about minus 20% in mobility compared to baseline, typical mobility when before COVID-19. Unfortunately, we are projecting if business remains the same, it will go up. I mean, this is the one by one for Qatar. I'll leave it for you, which is very important to look at. So what are the limitations? Excess mortality, we don't have what's the excess mortality in Qatar, especially early on. Nobody knew COVID-19 has entered the country. We have right now ICU beds from data originally from Qatar, but Qatar could increase its capacity and include more ICU beds. We don't have that data. They could add more beds. We don't know in the sample that they test, when they report, we have so many cases every day. We don't know how a sample is from. Is it from people coming to clinic, or is it a random sample for people who are outside? So we don't know the mix of asymptomatic, symptomatic, and that's very important. We don't have hospitalization data in Qatar. Excess mortality is every country. Every country is facing that. So if you look at Spain here, COVID-19 mortality and excess mortality, you could see a similar pattern. And we know we're underestimating COVID deaths in Spain, in a country that has good vital registration. In a country like Ecuador, where there is no good registration for deaths, you could see there is a huge difference between COVID reported and excess mortality in the country. And if you look at Ecuador, what happened in Ecuador this year compared to 2019 at the same time? Nothing except COVID-19. So we know in many countries we're estimating. If you look at the global, what happened with Qatar and many countries in the Arab world, all countries put the mandates in March. Every time was in like 2 weeks. This is the number of mandates we use. We have 6 mandates, and HME, I have a slide at the end about this for you. But this is the number of mandates put by country and when they put them. And you could see all countries put the mandates at the same time, around the same time in March. So what this has done for many countries early on, they didn't have a lot of virus circulating. They benefited a lot. And the circulation was stopped because of the mandate. Now that they're opening up, they have a full sense of security. And then the cases are going to pick up because this is a virus. You give it a chance, it's going to start going exponentially. So when New York closed compared to Florida, New York was in a much worse situation, and we still had a big epidemic in New York, whereas when Florida closed, they didn't have much circulation. So when Iran closed, Iran was too late because the infection started in early January, in mid-January. When country like Jordan locked down, it was so good for Jordan because there was not much infections going on, and Jordan benefited. So we need to keep that challenge for Qatar as we move forward. How you balance your economy with saving lives, shutting down or keeping it open, and how could you make sure that the behaviors as you ease the mandates, people don't let down their guard. So in the United States, not a good example for Qatar, but in the United States, when bars opened, there was a lot of outbreaks from bars. In South Korea, bars. So what events in Qatar will encourage super spreading? Mosques, wedding. I mean, these are the things that we have to be very careful. Plus, if you close down the business in a country like Qatar, what are the long-term consequences on health, not only on economy? By delaying services, people who have cancer, people who have diabetes, women who are not going for prenatal care, immunization. And not an issue for Qatar, but if you want to keep testing on, 1,000, 10,000 a day, PCR is not cheap, antibodies is more expensive, and that's, a lot of money. So a country like Egypt, doing 10,000 tests a day at $10 or $20, that's a lot of money on a daily basis. Or Pakistan, where would you spend that money? Not an issue for Qatar or the Gulf countries, but still something to keep in mind. So what Qatar needs to do in order to understand what's happening in Qatar, you need a random sample to make sure how many people are infected and how many people have antibodies in Qatar. So that's very important to know. And for the infections, if you're doing a random sample from the population, consider doing a panel in order to increase your power of detection. So you can do a small sample. So if you sample 500 at random in Qatar to do PCR and antibodies, But on a weekly basis, if you're doing PCR, keep 250 and randomly select another 250 and so on. So that way, before and after, increase your power of detection. Release your hospital admission so people, we can tell everybody, including, I'm sure the government knows, Qatar, my good friend, Dr. Muhammad has the data. You know what's happening in Qatar in terms of admission, but it's very important to know out of the cases that you are diagnosing, how many are being admitted to a hospital. That's very important. And then your testing, when you release a testing, what's the breakdown of the testing? Are they in health facilities? Are people that are exposed to somebody else? Or these are random people who said, I want to be tested? And how many people are you tracing after a case? And what's the percent positive among the people who are you tracing? So your cases, if you have a case in Qatar among Qatari or among foreign workers, how many other people came in contact with them? What's the average? And how many of those people who came in contact with that person turned out to be positive? It's a good idea to know how the virus is circulating. Can't make a presentation without talking about the prevention. Stay at home, wash your hands more than ever before, close contact avoided, keep a 6 feet, 2 meters, cover your mouth and nose. Even if you can't find a surgical mask, make something at home that is thick, close mask, do work, cover your sneeze and cough. If you're sick, stay at home, don't go out. If you have symptoms, stay at home, don't go out. Regular cleaning and disinfection of commonly touched objects. Travel is a big concern for Qatar, in my own opinion. You know, even a country like, and even a place like New York City, they were able to control R and lower it. I mean, New York is a great success story. It was late to act, but a great success story. But when you start opening and you have seasonality working against you, and then people start coming to Qatar, that's a major challenge. So travel patterns during the pandemic will be different than before the pandemic. But if you look at the data coming from Lebanon, the Lebanese government allowed people to come back to Lebanon. Every plane that comes to Lebanon, there's so many of them that are infected. And of course, they've been on a plane together for 3, 4 hours. So again, there's a risk for all of them and have to stay at home for 14 days and isolate. So that's a big challenge, opening here in the US, opening our airports, allowing visitors to come. So something to keep in mind as potential for resurgence. What can we do in Qatar? Now, I didn't show you the scenarios for 2.2 and 2.6 in Qatar because Qatar, until November 1st, we don't see a need for a lockdown. So, which is good news. But how can we do a lockdown? Should we target it to do it in age? In Qatar, it doesn't. I have it in the slide, you know, because something to consider, but it doesn't work. In Qatar, if I am in Lebanon, I'm living with my mom. So if you tell me, Ali, you're under 65, you can go out, but I come back and eat with my mom. So again, the age restriction in because of our culture, unless we isolate the elderly and we don't interact with them, maybe. Space and time, Qatar is a small country, very small country. So if we see a problem, should we lock down that neighborhood and don't allow people in and out? We've done it here in New York, in certain neighborhoods where we have a smart lockdown, where we locked a location. But time is the best thing in Qatar, is to have a short lockdown for 2 weeks, prepare for it if you need it. It may not happen, but prepare for it if you need it. Make sure people have what they need for 2 weeks. If we go into a lockdown for 2 weeks, we can do it successfully. And then, yes, by doing the testing and tracing, if there are hotspots in a fine neighborhood, maybe locking that neighborhood is the smart idea. But the problem in Qatar and in many parts of the world, people move around. If you lock a neighborhood, you know, we've seen it in Lebanon when they locked a neighborhood. Somebody will drive and, you know, show you a medication, say, I need to go and get this medicine for my mom or for my sister. And it makes it very hard. So it's very important to plan for a 2 weeks lockdown, be ready for it. Whether it happens, that's good. Plan for the worst, and hopefully it doesn't happen. We talked briefly about the vaccine and stop the promising trials. You heard yesterday one about one here in the United States, there are 4 in the US, 5 in China, 2 in England, 1 in Germany, 1 in Russia that are now actively in trial, moving to phase 2. The one that's in the US that showed the strongest protective effect, antibodies needed 2 doses. So keep in mind, we need 2 doses. If we have 1 dose, if we need only 1 dose from the vaccine, we need 8 billion vaccines because everybody in the world will need it. The logistics for delivery and distribution, it's very challenging. How could you store it? How could you deliver it? Say Qatar, if the vaccine is oral, that's easy. But if the vaccine is an injection, you need people to inject everybody in Qatar. So not buying it and storing it, but also distributing. Of course, when we have a vaccine, the priority is going to be for the medical staff. We're talking about 100 million doses. If at 2 doses, at least 200 million for the medical dose. And then when you give the medical staff the vaccine, who's next? And you have to be realistic. Is it going to be equitable? Is everybody, poor countries, poor people in India, Lebanon, Egypt are going to get the vaccine? Who's going to get it first? What country will get it? The US buy it for everybody and give it. What's the waiting time to get your vaccine once all the big countries who have developed the vaccine make sure that they give it to their own public? So vaccines are going to be here, but sometimes in 2021. So all what we have right now, we don't have a good medication, good drug for this virus. All what we have is prevention, and we have to be very careful to protect ourselves. Otherwise, we can't count on the vaccine or any drug. We can wear our mask, keep a safe distance in order to give time for our medical teams to find the vaccine. We compare our models to other models. I'm not going to spend a lot of time on this. We have a publication right now where we compare our models to a lot of other models that are out there. I'd like to stop here and open it for discussion. And thank you very much.
Thank you so much, Dr. Ali. So with this, we will start the Q&A session. So somebody was asking whether you are accounting for children going back to school into your projections of the spread of the disease.
Yes, so in places, we follow the mandate. So in places that reverse the closure of educational facilities, yes, that's taking into account. It's a very good question. Let me talk about schools. Schools is not only in the US, for example, it's not only kids going back to school, it's also the activities around the school, parents, meetings, sporting event, and a lot of things. So when schools closed down in the US, mobility went down a lot. We expect right now, even if schools open up, not much mobility will increase as in the past because many of the activities after school are being canceled. So yes, but we adjust for a mandate and for kids going to school in places that allow them to go back.
Okay, and if I can ask a follow-up question to that myself, I am aware that in certain countries, the social distancing measures are more strict towards adults having contact compared to children. So in certain countries, for example, children are allowed to have play dates, they go back to school, they have summer camps, but it's actually the adult contact that is more restricted. Could you comment on that?
No, we have in our all our data is by age, by sex. So we're accounting for infection by age, by sex. So that's one. Two, we're accounting for mobility because if you're moving children around, parents are moving. So there is a mobility index that we can adjust for it. The makeup of the key factor here is wearing mask and mobility. And the third one that I didn't mention is there is a survey in Google that tells us when you go out, how many people you came in close contact with. So we have a measure of social distancing as well that we can use for adults, not for children, of course, because adults respond.
Thank you. So the next question is related to the vaccines. Obviously, everybody is anxious to know what will happen there. Do you think it is feasible for us to have an effective vaccine within a certain time point, looking at, again, the spread of infection and the death rates across the whole of the world, basically?
So the good news about the vaccine, the good news is if you look at these vaccines, and without naming one of them, yesterday one of them was all over the news. The fact that they are right now in stage phase 2 or phase 3 of a trial, that's big. It doesn't happen. Usually take years before. So everybody is moving as fast as they can on this vaccination. And now that vaccine in the US is moving to 30,000 volunteers to take the vaccine. So now we're going even wider. And many countries in the world, the US, for example, has paid companies to produce the vaccine even before we know it's effective and it's safe. So this way, for the United States, as soon as a vaccine is found to be effective and safe, we will have about 200, 300 million doses that are already being made. What's the right dosage, how to give it, becomes more of a challenge because the way it's packaged right now is totally different. It's the mass production. So these are good news for many countries, but in reality, that's why I said equity in vaccine. For poor countries, what will happen, I don't know. If this vaccine is made public and then they released on the web how the vaccine is and allow every company in the world to make it safely, so company in India can start making the vaccine, that will help a lot. But short of like a global effort to provide vaccine and produce vaccines once we know they're effective, I don't think we will have enough vaccine by 2021 for everybody.
Okay, thank you. We have a next question from Dr. PK. He's asking, for places like India with larger, younger population and marginal daily income, are the lockdown guidelines good?
So in places like India and Egypt, where people have to, it's a very difficult situation. So you're putting a person in two options. You die from hunger at home, or you go out and die from COVID-19. And many people that I know, many of my relatives in Lebanon and in Yemen, they will tell you, no, I'd rather go out and not die from hunger than we die from COVID-19. So the lockdown will only work if the country provides support for people to stay at home. Otherwise, it's not realistic. And so in many cases in India, there was a good article about slums in India. Even during Ramadan, food was provided to houses, even for sahur. So even at night, they provided food. And it worked very well. They were able to contain the virus spread in that very dense population, vulnerable population. So that's a challenge for many countries. That's why I mentioned, like Egypt, $200,000 a day for 10,000 tests at $20. Where would you spend the money? Give it to people to stay at home or do testing? So these are very tough decisions that has to be country by country basis. And again, unless we support the vulnerable and the weak, we're not going to be able to protect ourselves. What COVID-19 showed, which is a very good question, showed the rich people in every country in the world, in the US, I'll give you an example, that there are poor, vulnerable people who are essential workers who keep the economy running during a lockdown. They go out. Meat packers, for example, in the US. If you don't protect them, they'll have an infection. You shut down the meat packers, then there is no meat for rich people who are staying at home. Same in the Gulf countries. In Qatar, if you don't protect the foreign workers, they're essential workers. They're going to keep your economy running. The rich people can stay at home. But once you interact with them, they're going to spread the virus. So things will change in the world based on what we have seen in COVID-19. Looking at social equity, socioeconomic equity, will be totally different, I hope. COVID-19 taught us a lesson that we are so interconnected, and the weakest of us, who is providing the basic services, has to be protected the same way we protect our physician in the hospital. Very good question. Thank you.
Yes, completely agree. We are all in this together. So yeah, everybody counts. We have another question from Jeffrey. He's asking, can you comment on the recent studies showing that immunity can be as short as 3 months for a high percentage of COVID positive patients?
No, these are very few. Problem with studies right now, because there's so much pressure on medical journals to review and publish peer-reviewed articles, the good ones, so everybody can post them online before they are peer-reviewed, and people pick them, start tweeting in social media. We don't know. We know that for the vaccine, they needed 2 shots to have the antibodies in them. We know from people, some studies, that if you have asymptomatic COVID-19, you have less antibodies than if you had severe symptoms. One study or 2 studies said that. One study in China that was published that you are referring showed, yes, it will decline a little bit. So I don't know 100% because it's too early to tell, but giving the evidence right now, I would assume that yes, it will go down, and we should be very careful with this COVID-19 that we could be susceptible again, like a flu. And you could get the flu and then you could get it again unless you are very careful. So assume for the worst, but the data is not 100% solid about this yet.
Okay, thank you. And then I have one question which is related to herd immunity. So there's quite a lot of controversy about herd immunity, whether there is or there isn't, and what is the percentage of infected people that should be considered when you talk about herd immunity?
Herd immunity is a concept in immunology that we use for vaccines when you reach 80 or 90%, depending on the vaccine. So for measles, for example, it's 90% covered. So basically 90% of your people can get measles because they are vaccinated. That's a herd immunity because you reduce the circulation of the virus. If you look at COVID-19 right now and take New York City, where we have in New York City about 23,000 deaths in a city of 8 million. The antibody survey showed 21% antibodies. So 21% antibodies, about 23,000 deaths. So that's not going to be achieved in a place in Qatar, in Lebanon, or in the United States without a large number of mortality. That's one. Two, herd immunity means what we are seeing right now in Texas and in Florida and in Arizona. It means you reach a point where your hospitals are overwhelmed before you reach herd immunity. And then the decision is who you keep alive, who you put in an ICU, who you put on a ventilator. I don't think countries are ready for that. In my opinion, herd immunity is a failure. We basically surrender and we say, let people die. And that's not acceptable. So from a public health, from a humanity, herd immunity is not an option. What we have to do is prevention. Lockdown, if we have to lock down for another 2 weeks, that's okay. We come back again and open our businesses. The uncertainty for businesses is what's scary. But if you tell the businesses in Qatar, like in November 15, you're going to lock down for 2 weeks, they'll plan for it. And it will be less impact on your economy, and people are being ready for it. So certainty is very important in this time where everything is uncertain. Herd immunity is not an option, no.
Okay, thank you so much. We have one more question from Ghada. She's asking, did we consider swimming pools as a media for transmitting the virus?
I don't think the data is there about swimming pool. It's more about interaction and how close people come together. So in the US, when lakes, you've seen the lakes photos or the beaches open, it wasn't the beach itself, the water itself. Pools sometimes, I mean, well-maintained have chlorine, kills everything. But no, it's more of the people getting together and letting down their guard, you know, yelling and screaming and partying, especially around alcohol. When alcohol effect takes off, people take off their mask and come closer to each other. So that's the problem. It's not the environment, it's more of the how people are close to each other. The only thing to keep in mind in Qatar in summer is outdoor, indoor. We know outdoor there is less chance of the virus to circulate because it has more room to disperse. Indoor with air circulating, and in Qatar being hot in the Gulf, and now people moving indoor and having parties indoor, it's much worse than having a party outdoor. Parties are not good right now without masks and staying away from each other. But that's a major concern, especially events in the Arab world right now where they are done inside and in a conditioned circulated air environment. So that's a big problem.
Okay, and then maybe we have time for a last question. In the beginning of your talk, you were mentioning that you're accounting for pollution as part of as one of the covariates. Can you maybe elaborate a little bit on how pollution affects the model?
Because we put it in checking, it's a lung function. So if your lungs, that's why we have altitude. If your lungs and heart is stressed in order to secure oxygen for you, and you have a COVID-19, that's even more of a risk factor. So we put it in the model, and it's significant. It makes a big impact. So, and we're picking particulate matter 2.5. Why we're picking that? Because we have data by satellite. HME has data by satellite. We can have 1 by 1 kilometer, what's 2.5. We could have it on a daily basis. And then we have done a lot of work with particulate matter, part of our global burden of disease, where we validated the satellite data to the local measurements. Countries report, they have stations, they report all these environmental variables. In the US, we have stations all over. So we validate the satellite to the reported data. We have a good measure of particulate matter.
Okay, thank you so much for the very interesting talk. With this, I will end the Q&A session. And I just have one more announcement to make. I just wanted to have the final remark that the webinar is recorded. So for anyone who would like to revisit the webinar, there will be a link sent to all the attendees. And then you can share it also with your friends or whoever you think would be interested. Second, there will be also a short survey when the webinar closes. So please feel free to give us any comments that you might have. And as a final remark, thank you so much, Dr. Ali. I learned a lot from you today, and I hope our attendees as well. For me, the take-home message is basically keep wearing your mask. Our new normal will be a new normal. We will be wearing masks at least until November. Who knows, 2021 might look different as well. So, but we're all in it, and I mean, we're all in this together. So hopefully we will beat it. So thank you so much, everyone, for attending. And thank you so much, Dr. Ali, for giving us your talk.
Thank you.